Thank you, Himanshi. So good evening, everyone. On the behalf of PHO chapter, I extend a very warm welcome to everyone, especially to our esteemed faculty members, Dr. Manish Agarwal, and panelists, residents, fellow pediatricians, and orthopedic surgeons who are joining today for this PHO National Teaching Program. So today the session is going to focus on the osteosarcoma in children. And as we all know that osteosarcoma remains one of the most challenging pediatric bone tumors, not only because it is aggressive in nature, but also it demands a truly multidisciplinary approach, which involves the pediatric oncology, orthopedic oncology, pathology, rehabilitation, and psychosocial care. Over the years, advancing in chemotherapy, imaging, limb salvage procedures, prosthetic reconstruction, and precision surgical planning has dramatically changed the outcomes and quality of life for children who are affected with disease. It is now my great privilege and honor to introduce our keynote expert for the evening, Dr. Manish Agarwal, sir. Dr. Manish Agarwal, sir, is one of the most respected names in the field of orthopedic oncology in India. He is the vice chairman and senior orthopedic oncologist at Max Nanavati in Mumbai, and he has made immense contributions to the field of bone and soft tissue tumor surgery, limb salvage procedures, and prosthetic reconstruction, which we are going to hear today. He is widely admired for his expertise in managing the complex musculoskeletal tumors and for his commitment towards preserving both survival and quality of life in children and young adults with bone cancers. His work has significantly advanced the concept of limb preservation in India, giving hope and improved functionality to countless patients and families. Today, he is going to share his valuable insights on saving limbs, preserving futures, prosthetic reconstruction in bone tumors. So, sir, very much thank you for joining us today and for taking out time to enlighten us. Over to you, sir. Thank you so much.
Thank you so much for having me.
So we can't hear you.
Can you hear me now? Hold on. Just let me see.
It's better, sir.
Okay, you can hear me now, but I think as soon as we start sharing the screen, is the slideshow visible?
Yes, sir. And voice is also perfect.
Okay.
Thank you, sir.
So is the whole screen visible or is a part of it being missed out?
No, whole screen is visible.
Fine. So I think today I'm just going to briefly give you an overview of what we mean by limb salvage and what are the various things that we do when we are looking at limb salvage, particularly in children specifically. And all of us who deal with children actually know this, that children are not adults in a small package. They're very different individuals, and there are a lot of considerations that you have to give to children which you don't have that in adults. Orthopedic wise, very specifically, their bones are smaller. The metaphyseal bone is very soft because it is new and it is just coming from the growth plates. Most of the implants that we have in orthopedics are actually not designed for children. They're designed for the adult bone, and therefore fitting them in children is often very difficult, particularly when there is a little bit of distortion which you get because of the tumor. There is going to be some kind of destruction, enlargement, bumps, which make it difficult to fit in things like plates. We also have to make sure that we don't damage the growth plates, because that is what we want to preserve. And if we do have to resect the growth plates, then we have to compensate for the growth loss. So what do we actually do in limb salvage surgery? So if you see from this picture, you will see that we remove the tumor along with some margin of the bone, and then we reconstruct that gap back. Now, most of the tumors are actually close to the joint because they arise from the metaphyseal area. So a majority of reconstruction will require some kind of a prosthetic reconstruction, because when we remove the tumor with the margin, a part of the joint is going to be excised as well. So if you look at this picture again, you will see that we put a joint in, and this joint is expandable. That means we should be able to lengthen it if you are expecting that the growth of the child from that particular resected growth plate is going to be more than 3 centimeters. Now, how do we calculate this is pretty complex. There are now algorithms. There is a software called as Bone Expert. And you all are probably aware of the various methods that we use to predict what is going to be the actual height of the child. And from that, you can calculate how much is the remaining growth from a particular growth plate. So let's understand also that the loss of growth is not only from the growth plate which is resected. Now, if I put a joint in the knee, for example, for the distal femur, you will see from this picture that you will lose about 20% growth also from the proximal tibia. And this has to be taken into the calculations. Now, if we do it, if we replace the proximal tibia, then the growth loss is even more. We lose about 40% from the distal femur and 100% from the proximal tibia. So that's why when we calculate the growth, we look at these formulae, look at how much is the growth loss which is going to happen, and then decide whether we require something which is expandable prosthesis or whether we can put a regular prosthesis. Now, if you have a regular prosthesis, like you have in this girl who was 15 years old, you can see that the adult prosthesis results in extremely good function. Very often you can't even tell which side has been operated. And we don't have to think much about these kind of reconstructions. They are standard run of the mill, and almost everybody today, all the orthopedic oncologists in the country are able to do this well. The problem comes is when you have significant amount of growth remaining from the growth plate, as you can see on these cases. That is when you need an expandable prosthesis. So what do you mean by an expandable prosthesis is what you can see in this video. You are able to lengthen the joint. Now, what I'm showing you on this video is what is called as a minimally invasive expandable implant, where you have to turn a screwdriver from that slot in order to operate a worm gear, which allows that cylinder you saw with telescoping out and giving us that length. Now, this can be done periodically as the child grows. You do, say, 1 centimeter at a time. Maybe you'll have to do it 4 times or 5 times, depending on how much the child is going to grow. This is an example of one such patient. You can see this was an osteosarcoma. We put in this expandable prosthesis, and she had about 4 expansions from this prosthesis to keep her limb length discrepancy within 2 centimeters, which is what we aim at. And once this was done over a period of 4 or 5 years that she grew and then finally became an adult, unfortunately, she developed a lung metastasis. You can see here a large lung met, but it was a single met. So she underwent a metastatectomy. And after metastatectomy, 2 years passed, she did not develop any disease anywhere else. So one important point to remember is that even if we put an expandable prosthesis, we need to convert this into an adult prosthesis when the skeleton becomes mature. So we did that for her. And she's become a doctor. She's at JJ Hospital. She's actually finished her MD in obstetrics and gynecology. So what are the problems with this kind of a prosthesis? The risk is that this requires surgery to lengthen the implant. Now, if you need surgery, which means you're making a cut onto the body, you have a risk of infection with every lengthening process. Although it's a small cut, the cumulative risk becomes pretty high, particularly if you need more number of lengthenings, and this is more with the proximal tibia than with the distal femur. because we are also trying to lengthen as much as we can in order to reduce the number of lengthenings, you tend to become a little stiff. Physiotherapy is required again to gain back the range of motion at the joint. And sometimes you will need to revise this joint because they could break, they could become loose like in all other prosthetic joints. And importantly, it is never one surgery to put in the prosthesis. As I said, you have to change this into an adult prosthesis because the child is going to be heavier and bigger when they become skeletally mature and they require an adult kind of prosthesis. To circumvent these problems, we now have what is called as a non-invasive expandable prosthesis. You can see in this video, as you switch on the current in that coil, the coil actually generates a magnetic field which turns the gears which are present inside the prosthesis. And this does exactly the same thing that we were doing manually with the minimally invasive expandable prosthesis. You get lengthening. So every 4 minutes, we would get a millimeter of length. Now, this did not require surgery, could be done on an outpatient basis. So we could do it more frequently. Every time the child came for a follow-up, we would lengthen this child in a more physiological way without causing any pain, without any risk of infection, and without any stiffness. So these kind of implants we were able initially getting from Stanmore. This is an example of one such case. You can see osteosarcoma with a pathological fracture, which we replaced with a non-invasive expandable prosthesis. You can see here, we almost lengthened him by 9 centimeters by the time he became an adult. And you can see here on both the videos, one as a child, once the prosthesis was done, and one now you can see as an adult after he's been revised into an adult kind of prosthesis. Now you can get the length, but it doesn't change some aspects of growth. Now, if you look at their foot size, the foot size is different. There is always a difference of 1 or 2 in their foot sizes, and this is something which we have to tell them that they may have to buy 2 pairs of shoes in order to get a proper fit. Now, this particular prosthesis now is not available because Stanmore has shut down and we now use a different prosthesis. The advantage of this Mutars prosthesis is that you can do the lengthening at home. The child doesn't have to come to the hospital. So this is the lengthening apparatus that you see, and there is a cable which is under the skin. So that this is a transmitter which the parents can use at home. It is put over the receiver, which can be felt under the skin. And for the fixed number of pulses that you teach them how to give, you can get growth. So this can be actually done on a daily basis or on a weekly basis. And it is far more physiological, just like normal growth, which happens. This is an example of a child who actually didn't get an expandable prosthesis at the time of original surgery. Now, when she became an adult, she was very, very debilitated by the shortening you can see here on this leg. So she was converted into first an expandable prosthesis. You can see the metallosis around this old joint. This is a new joint which was put in, the expandable, non-invasive expandable. And we managed to get her the length, and you can see how her gait has changed and how much his life has improved. And we've again had to convert this into an adult kind of prosthesis. So it's not a small amount of surgeries or a small number of surgeries that are required. When we do an expandable prosthesis, we have to explain to the family that it is going to be multiple operations that are going to be required. Now, there are times when the tumor is a little proximal, and that is the time when we may be able to preserve the joint. But here again, the challenge comes in children is that if we have to resect the growth plate, then there is no way in which we can just put that bone back and expect growth. So we put now what is called as a expandable joint sparing implants. So we'll show you an example of that in this child. She was 10 years old when she had an osteosarcoma, and these are custom made to fit into that small piece of the joint which is remaining. And this can be grown or lengthened like the prosthesis. The difference is that this is not a prosthesis because there are no moving parts. So we don't have to change this into an adult kind of an implant. And this again, girl has become a doctor. She's at Maulana Azad Medical College. And this, what was done about 10 or 12 years ago, is continues to be fine without any problems related to the implant. All these implants are very expensive. So if you are looking at the non-invasive expandable prosthesis, which I showed you, uh, in today's pricing, they cost approximately between 24 and 30 lakhs today. Even the conventional adult kind of prosthesis, the imported prosthesis costs somewhere between 5 and 6 lakhs. So this is beyond the reach of most of our patients. So we have jokingly used this picture. You can see this implant lying on this car. And this was taken 20 years ago when the Santro cars were still available. And we told everybody that the car and the implant cost the same, showing you how expensive these imported implants were. So that actually was a stimulus for us or an incentive for us to start making our efforts towards developing a good prosthesis, because whatever indigenous implants we had at that time were very poor quality, and they would actually fail very early and cause more problems than the disease in those children who survived the disease. Now, how important an indigenous implant is, you can see from this case. This was a boy who developed bone cancer when he was in the 8th standard. And he was treated with something which we started with simple stainless steel hinges, which would be made for a cost of rupees 15,000. Coming from a low socioeconomic status, that is all what they could afford. But because he had limb saving surgery, he went on to come on the merit list. He got scholarships. He became a software engineer. And when he needed a revision, he was able to actually spend for his own implant. He now actually takes care of his family, and he is the only person who is able to contribute to the family income, as his father has now retired. Now, had we not done that limb salvage, this probably would not be possible for him. So we started this project where we got some of the best engineering talent, and we got funded from the Office of the Principal Scientific Advisor, Government of India. The whole story is actually more interesting, but we don't have time for that today. But we got together a team from IIT Bombay, from Non-Ferrous Technology Development Corporation, which is in Hyderabad. And to give you an idea of what NFTDC in Hyderabad does, is that they were the ones who made the cryogenic engine possible, which allowed our Mars mission or the moon rocket to go because of developing that alloy. So they did high-end work, and they were the ones who who were going to manufacture the implant once we had our design. So we had a lot of effort. It took us 15 years actually to develop the knowledge base, studying everything right from the metals to the biomechanics to the manufacturing processes, because nobody would share this information with us. We also wanted this implant to fit into our Indian population. So we had to do our measurements, anthropometry, and we got the measurements done. And our sizes are now available as far as our population goes. It's also manufactured at NFTDC in a very state-of-the-art facility. You can see these are the 5-axis CNC machines. These are the same machines that are used by the multinational companies also, which make the imported implants. The difference now is that, again, this is a robot which is used for surface finishing, exactly again like what the multinationals use. The tolerances are also checked. These are lasers which actually check what are the diameters and the surface finishing, so that the implant that we now have matches with the imported implant and actually exceeds or betters the imported implant by in some of the aspects. Now let me show you what this looks like. Now, if you see, this particular implant is the imported striker implant, which is used currently most of the times. This is the most commonly used implant all over the world. And you can see that it has a rotating hinge and that rotation is free. There's no control over it. So patients at times find it difficult to control it when their quadriceps muscle is weak. Now, as compared to that, this is our new implant. And you can see that the rotation is actually occurring at the center of the knee, like in the natural knee. And this, therefore, keeps the patient very stable, particularly when climbing upstairs or downstairs. We have started the clinical trials of this implant. Almost 70 of these implants have been done. You can see this was the first patient who was done 6 years ago. He still maintains this normal function, very similar to what you have seen with the imported implants. We've also indigenized the minimally invasive expandable implant. So instead of the 14 lakhs that it used to cost, it now costs only 2 lakhs. And a lot more children are able to afford now this kind of an expandable implant. The very young children are probably the most difficult to treat. So while I showed you cases with the expandable implant where you could grow maybe up to 7 or 8 centimeters, that was possible to do, it's now quite routinely done. What do you do to a child who's just 5 years old and the growth is massive? Our biggest problem is that even the implants don't fit them well, even the custom made implants. So I had great difficulty in getting this implant made for this 5-year-old boy. There was only one company which was able to make it. We made it and we did it and we lengthened this child, because of which he ended up with a flexion deformity for some time. As he grew, this flexion deformity corrected, but this implant didn't lengthen. So we had to change this into another non-invasive expandable implant from Stanmore. We were able to lengthen this implant about 4 centimeters or 4 or 5 centimeters. And then we had to again change this into another expandable implant which could lengthen 9 centimeters. So this was a non-invasive expandable at this time. Now this got lengthened again. And by the time this boy became 15 years old now and his length had corrected, this implant now broke. And we had to revise this now into an adult kind of implant. And this video shows that in spite of so many surgeries, I have lost count of how many surgeries he's had, probably 10 surgeries, including the lengthenings, he still maintains good function. But a lot of things could go wrong in this process, particularly if infection happens. So rotation plasty is a very good alternative for these very young children. The concept of rotation plasty is that you remove the segment, you shorten the limb after rotating it 180 degrees. So you can see in this graphic, your ankle joint now is becoming the new knee joint. And you put in an prosthesis below it, an orthosis. So you're controlling the knee. You've got sensation on the sole, but the shortening can be taken care of. You don't require to keep lengthening this. So it's a one surgery procedure. And you can change the external orthosis from outside as the child grows. Functionally, this is as good as the prosthesis. In fact, many times better, because these children are able to participate in sports. And they're able to do most of their activities, including driving a motorcycle. It can also be used as a salvage procedure when things go wrong. This patient had come to us from Oman, who actually had a non-expandable implant which had got infected. So she ended up with shortening and very severe infection, which was salvaged with a rotation plasty. And now she's pretty functional with the rotation plasty. Again, a 6-year-old boy where a proximal femur was resected for an osteosarcoma. Now, at 6 years of age, there is enough growth even from the proximal femur. And you can see over a period of time that his hip became dysplastic. And because of that dysplastic hip, he started subluxating. We had to do a shelf osteotomy to correct it. But this was not the end of trouble. Once that lengthening has been done, you can see here, he ended up falling down and getting what is called as a periprosthetic fracture. These are very difficult to treat when the bone is very thin and there is a stem inside. We've managed to correct that, get him out of that problem, and he's now back to walking. But again, this illustrates that problems are never over for these children who've had surgery done or an expandable prosthesis done at a very early age. 3D printed implants are giving us solutions where we are doing biological reconstructions. This 4-year-old girl with a distal tibia osteosarcoma could not have been salvaged with this method that we have used. We've resected the distal tibia, done ECRT, and put that bone back. And we use a custom 3D printed plate to fix the talus to the tibia. Now you can see this worked very well for this girl. She's now about 6 or 7 years from her surgery. She's grown quite a bit. But again, you can see that the foot size is always going to be smaller than the opposite side. Now, if you can preserve both the joint and the growth plate, then you can just radiate this bone and put it back. And you can see in this case, this patient actually had a debridement done on suspected infection because they didn't do a biopsy before assuming this was infection. Now, this patient was advised amputation almost everywhere, but when we saw his MRI, we thought we could excise that contaminated area. We could excise that bone and put it back. So we got a 3D printed plate made for him, and we radiated, put back that implant, and we did a free ALT flap for him. And that allowed us to salvage him. Proximally, the hold was very weak because of the soft metaphyseal bone, so we had to put in another plate, and that allowed his bone to heal, and he has extremely good function today, as you can see on this video. Sometimes the challenge is even bigger. You can see in this case that the distance between the growth plate and the disease was very, very small. So here we actually first fused the CT with the MRI. We got a 3D printed plate made, and we used navigation to be certain that we were enough distance away both from the disease and from the growth plate. You can see in this video that navigation allows us to get a real-time idea of where we are, and we are able to then get the margin that we want with confidence and also preserve the growth plate as we were able to do in this child. So this is how the post-op X-ray looked like. So I'm going to sum up and leave you with just this case at the end, saying that pediatric reconstructions are challenging, but they're also rewarding. This was a 2-year-old boy with an Ewing sarcoma, and he was going to get hip disarticulation done. The medical oncologist sent it to me asking whether we can do anything better than an amputation. So we worked out this plan, and this was before the 3D printing era. We got a custom plate made for him. We did that same plan. We resected that bone in between, which was almost 80% of the length of his femur, radiated that bone, put it back, fixed it with that plate. You can see over time that bone has grown from both the ends, and this boy actually has a pretty normal life. Nobody in his school knows that he's had this kind of surgery done. So thank you very much.
Thank you, sir.
Yeah, continue, Ajita, please.
Thank you, ma'am. So thank you, sir, for that wonderful session. Actually, it was very inspiring to hear the journey from what we were using from abroad with regards to the expandable processes, expandable implants, to our own indigenous solutions, like what we have in cellular therapy. We have our indigenous CAR-T. So
Correct.
we have our indigenous solutions, which is better than what was available. And to hear many inspiring stories, especially it was touching to hear about engineer who is the sole breadwinner and who has got an indigenous expandable prosthesis. And with regards to the last child whom you had shared the journey, and this definitely gives us hope in treating children with osteosarcoma, and to know that these are the real advances which are happening in the fields of surgery. Thanks a lot for taking us through all types of surgeries. Thanks a lot, sir. So we'll move on to the next session, which will be, I think the questions can be taken up at the
Just one question.
end of the session.
Just one question from sir. I mean, we are just continuing this.
We can allow a few questions. Yeah.
Yeah. Sir, just one question. Excellent lecture. I just wanted to ask, like, for the children who have this osteosarcoma, how many percentage of your patients are undergoing this expendable prosthesis?
So I think today almost every child who is suitable for it gets an expandable prosthesis, because we've set up a unit at Vadia where Can Kids is the NGO which is supporting it, and uh, almost every child who needs an expandable prosthesis gets one, because we've indigenized it and we are now able to, even the NGO is able to support that 2 lakh cost for the implant. So we've done quite a few of those, and some of them have gone on to become now adults, and we've replaced them now with the adult kind of prosthesis. The adult kind of prosthesis that we have is waiting for the drug controller's clearance, but it should happen very soon because it has got ISO certified now. And that could become available at all our regional cancer centers. So I think every individual today in the country who needs prosthesis for limb salvage should be able to get one without having to worry about the cost on that.
Great, sir. This was very nice to know. Thank you so much. Yeah, Ajita, we can go ahead with the panel discussion. Sorry.
Yes, ma'am. Yes. So it's nice to know that CanKids is supporting. We do have CanKids supporting many of the centers in India. So we would reach out in case of need. The next session will be panel discussion by Dr. Benita. She is a professor of pediatric oncology at RCC Trivandrum. I hand over to her to introduce the panelists and take over the session. Thank you, ma'am.
Thank you, Dr. Ajita. But can you just guide me on how to start my screen sharing? I think I'm not a host.
One second, ma'am. I think you should be able to share it now.
Yeah. We can see your slides, Dr. Binida.
Ma'am, you can start your session, but we're not able to hear you.
Yeah, good evening all. So today we'll have the panel discussion on osteosarcoma, how to navigate complex decisions from diagnosis to relapse. But since this is more of an online teaching program for the PHO session, PHO fellows and students, we have tried to start off with both the simple as well as the complex decisions. So to start, I will introduce my panelists for the day. We have just listened to Dr. Manish Agarwal, the eminent orthopedic oncosurgeon from Nanavati Max Hospital, Mumbai. The second panelist is Dr. Sandeep Jain, who is a consultant of PHO and BMT at Rajiv Gandhi Cancer Institute, New Delhi. We have Dr. Badira, Professor of Pediatric Oncology from Tata, Mumbai, and Dr. Sindhu, who is the head consultant oncopathologist from Ganga Hospital, Coimbatore. So as we are all aware, osteosarcoma is the most frequent primary sarcoma of the bone. and it's primarily diagnosed in adolescents and young adults. There are the approximate like incidence is around 2 to 3 affected individuals per million person years. As we can see, it starts usually around the age of 8 to 9 years, gradually peaks at around 16, 17 years, and beyond the age of 19 or 20 years, it's less common. So it's mostly a disease of the adolescents and young adults. Coming to the treatment modalities for osteosarcoma, it includes chemotherapy and surgery predominantly. Radiation is used in very rare situations, but there are certain situations where radiation can be helpful, which we'll be discussing today. And so definitely we need a multidisciplinary team for the management of any child with osteosarcoma. So we'll start with the case today. So this is a 14-year-old male child who presented to RCC with complaints of pain in the upper part of left thigh of 1 month duration and a swelling of 3 weeks duration. There's no history of any skin discoloration, discharge, or ulceration. There's no history of numbness or paresthesia. There's no history of any native treatment, with no family history of cancers, and there was a very visible swelling in the lateral compartment of the left thigh. The joints were spared. There was no restriction of movements. So this was the initial X-ray that was taken from outside hospital. And what we could see was there was a predominantly sclerotic lesion in the proximal end of femur. If more than 50% of the osteosarcomas occur usually around the knee joint, but this was more towards the proximal and middle portion of the left femur. There was a significant soft tissue component. There was a periosteal reaction. There was a Codman's triangle, and we could see the ossification within the soft tissue as well. So we proceeded with the MRI. And I would like to hear from Dr. Manish regarding the importance of MRI, the initial MRI, from an orthopedic oncosurgeon's perspective, how it helps you in making local treatment decisions.
So I think the MRI is an absolutely necessary part of the workup for the patient, because the X-ray cannot show us the extent of the tumor like the MRI does. And whatever local treatment we are planning or limb salvage surgery is planned on the initial assessment when we are doing our initial workup. Because if you need to order a custom implant, you will do it on the basis of this MRI, because it takes some time to get custom implants made. Even if you had a ready to use modular implant, you have your plan ready. We also know that the MRI extent in osteosarcoma is not going to change with chemotherapy. It doesn't change much like in Ewing's, where the soft tissue regresses completely. In osteosarcomas, that extent is going to remain the same, and you plan everything on the basis of this MRI. You can see where the neurovascular bundles are. You can decide whether the limb salvage is going to be possible or not in the borderline cases of that. So MRI is extremely important. What is very important is when you ask for an MRI as a primary physician, you must make sure that you tell them you're suspecting a tumor, because if you say MRI knee or an MRI hip, you will tend to get only small parts of the disease or the tumor covered. They don't cover that entire tumor. So we must screen that entire bone, because you sometimes will see skip lesions in the same marrow. And that is something which is very important to tell the radiologist that we are suspecting a tumor and do the tumor sequences. The standard sequences for trauma are different from tumor sequences. So it's very important to write on the prescription that you are suspecting a tumor.
Thank you, Dr. Manish. So this MRI showed a large tumor, significantly large tumor involving the most the proximal and the mid portion of the femur. So we proceeded with a true cut biopsy from the thigh mass. Again, whom would you suggest? Who is the best person to do the true cut biopsy? What is the type of biopsy that you would recommend in such an aggressive tumor? Are there any points to be kept in mind before doing a biopsy? Dr.
Yes,
Manish.
so I think the very important point is you must decide what is going to be your plan in terms of limb saving surgery so that your incision can be drawn. So even if you are sending this to a radiologist to do an ultrasound guided biopsy or a CT guided biopsy, they know what is going to be your line of incision and they can place their biopsy site along that line of incision. So it doesn't matter who does the biopsy, whether it is a surgeon who's going to do it or the radiologist who's going to do it. It has to be the same team which knows what's going to be the plan of surgery. The plan has to be decided before you even do the biopsy on that. So that is the important part. It's always a needle biopsy for us. I think in the last 5 years, I've hardly ever had to do an open biopsy. We always manage to get a diagnosis from the needle biopsy.
And one of the most important thing is that we definitely have to complete the imaging studies, preferably correctly identify a representative area, and then take the shortest route to the tumor. We should try and violate only one compartment, and the biopsy tract should be as distant from the neurovascular bundle as possible. So these are some basic principles that we should follow while we are doing a true gut biopsy. So this was the histopathology. I have Dr. Sindhu from Ganga Hospital. Dr. Sindhu, could you please comment on the histopathology slides of this patient?
Yes, ma'am. Here we have seen two images. The first image is a high power image showing the tumor. It's predominantly of chondroblastic subtype, where we can see some atypical chondroid areas as well as some dense sclerotic bone here. This sclerotic bone with the tumor cells which forms the tumor part here. This is mostly composed of atypical chondroid areas with this pleomorphic tumor cells, and the cells have a nice polygonal shape with central to eccentrically placed hyperchromatic nucleus here. And the second image also shows, which is a low power image showing a similar type of atypical chondroid areas with some pale pink osteoid areas here. So this is definitely a pleomorphic high-grade tumor, which is an osteosarcoma. And this biopsy shows predominantly chondroblastic subtype of osteosarcoma.
Is the histopathology going to be of any use in diagnosing an osteosarcoma? It's purely a morphological diagnosis.
Yeah, it's purely a morphological diagnosis. The subtype is purely a morphological diagnosis, whether it is chondroblastic subtype or osteoblastic, or it is fibroblastic subtype. Clinical impact, to some extent, it depends. In our study, we have seen that chondroblastic subtype has a very poor response compared to conventional osteoblastic and fibroblastic subtype of osteosarcomas. And the role of IHC is very minimal in diagnosing a conventional osteosarcoma. The morphology gets an upper hand in diagnosing conventional osteosarcoma. In few cases, marker like SADB2, which helps to identify some poorly differentiated subtypes and dedifferentiated osteosarcomas.
Right. So apart from the conventional osteosarcomas, we additionally have the telangiectatic and the small cell osteosarcomas, which maybe behave a bit more aggressive than the conventional osteoblastic osteosarcoma. And once we have got the diagnosis of an osteosarcoma, we proceeded with the metastatic workup. We did the PET-CT, and the PET-CT showed the uptake only in the primary tumor area. There was a low-grade uptake, which was reported as reactive or probably an inflammatory change only, and no biopsy was done. So, Dr. Badra, what would be the metastatic workup that you would advise in a diagnosed osteosarcoma or a suspected osteosarcoma? There have been a lot of discussions whether PET-CT alone will suffice the way, or bone scan plus NCCT thorax. Do they balance well with the PET-CT? Are they can we equate the two?
Sure. Thanks, Vinitha. So your staging workup rightly depends upon where your disease is going to metastasize. So all of lung is the most common site of metastasis, and you can also have bone metastasis. And these are the two systems, organs you need to look into to see whether it is metastatic or not. So if you look at earlier, if you look, it was bone scan which would look into the bone mets, because bone scan would pick up the osteoblastic activity wherever there is. So bone scan was used to do the skeletal metastatic survey and non-contrast CT thorax for lung mets. So this was earlier used. Now with FDG PET. PET CT is widely used. Now, if you look at the when you say I'm talking, it should be FDG PET not alone, but it should be an FDG PET CT. There should be a CT combined with the PET this thing. Then you can use it as a one-stop investigation for staging, which would take care of the bone metastasis as well as lung, where the CT component, especially if you have an older child, a breath hold CT what will be recommended to look particularly for the presence of lung metastasis. So if you have a FDG PET CT, that can be rightly, because it has got a high sensitivity and yes, a very good specificity to detect these two metastases. And as I said, breath hold CT in an older child is what is recommended, vis-a-vis bone scan plus NCCT thorax. You can use either of it, but in right now, I think FTG PET is more common. The machines are more common than a bone scan, because a bone scan would require a gamma camera or a SPECT CT. So that is not freely available. So if you look at it, widely available is PET CT, and they right now they do equate fairly well, and you can use FTG PET CT, because I think for most of the pediatric tumors, we are using FTG PET CT as our staging investigation. So, and the false negativity with PET CT and all is fairly very rare, and I don't think when you have a CT component add to it, that would fare very good, and you can use FDG PET CT wherever available as a staging investigation. Now, fluoride PET, so fluoride PET, the difference between an FDG PET and a fluoride PET is in the tracer. So fluoride is a tracer, and as you know, fluoride is a bone-seeking tracer. So wherever there is osteoblastic activity, you can have uptake and lighting up in when you use a fluoride PET CT. And as we all know, in osteosarcoma, it's an osteoblast. There is osteoid forming mets, and hence fluoride PET CT can help detect the skeletal metastasis as part. And again, it is not widely available as such, and hence we stick to FDG PET CT wherever it is available. In TMH as such, we are using bone scan because we have bone scan and NCCT thorax as a staging investigation. So you can choose among both of these. So for osteosarcoma, fluoride PET CT is okay, because osteosarcoma usually metastasize to bones, and we don't get other soft tissue and other mets where it might be difficult.
Apart from the initial diagnosis, the PET CT response, whether it is able to predict the role of necrosis, it's widely discussed these days. So what is your take on PET response assessment using a PET CT, or whether you can predict necrosis with the PET CT?
So it depends, what are you going to do with that? So that would be my first thing. Now, when are you going to do that? Yes. So PET CT response, again, you are trying to, so you are trying to equate it with the histological necrosis. And we all know, because histological necrosis is an important prognostic factor in osteosarcoma. Having said that, whatever we have done, once we have found that they are poor responders, to change the outcome has not worked. Intensifying therapy based upon that histological response has not worked into a survival benefit, but we can prognosticate. Now, again, why do you want? So it again depends upon when do you want to time that. So doing the same at the time of response assessment after NACT, you using your PET CT to identify good or bad response. I don't know how that is going to help, because even the histopathological has not worked. Now, it would have been helpful if you could know it upfront or immediately upfront. Where any modification, is that going to change your necrosis and outcome? We don't know. So that we don't know, even though intensifying an NACT in many of the trials that have been done has improved your percentage of good necrosis, but has not translated into a survival benefit. So nothing which has been done either upfront or after knowing that they are poor responders has translated into a survival benefit. So I don't know what we can do understanding that, but Having said that, a PET CT immediately after first cycle has been shown to be prognostic with respect to OS and has been shown to be fairly predictive of your histological response. So there are cutoffs for that, especially your SUV max has been shown to be associated with the better. And when you are comparing the baseline and the response, the delta SUV has also been shown to correlate with your histological response. At this juncture, we don't know what to do with it. So I would put it there.
Yes, sure. So,
Just, Adira, may I
Yeah.
ask something?
Sure.
How common it is to have a skeletal mets in absence of pulmonary metastasis?
It's very rare. It is
Very-
very rare because it's commonly lung mets, but we do have, I mean, very rare cases where you have bone mets of osteosarcoma, but they are less than 5% or less than 2% as such, less than 5%. So 95% of the time, if you have a metastatic, you would have a lung met and then it metastasizes. But yeah, less than 5% you can have.
Actually, I was listening a talk from the Memorial Sloan Kettering, and they do only CT chest. They don't do even bone scan. And if CT chest doesn't show anything, they are not doing any other staging workup. So I was wondering whether in patients, really PET scan is required for everyone. And in case the CT chest is normal, do we need any other staging workup?
So yeah, so that's what Sandeep, the percentage of metastasis with only bone is very less. So less than 2% or 2%. So that's something we can critically look at. Having said that, even if you look at rhabdomyosarcoma, so rhabdomyosarcoma, we are using FDG PET CT. Again, if you don't have lung mets, in many situations, they don't have bone mets. But still, current standard of care as such, the staging workup that is recommended across guidelines and this thing, still doing a bone scan.
Right. I agree.
Let me put a surgeon's take on doing a PET CT.
Yes, sir.
So we do it because to me, the information, whether the patient has responded or not, is very valuable because we do a PET CT before we start therapy, and then we do one after the induction therapy as well to know the response. Now, Badira did ask a question, and we all asked, even if you knew the prognosis, how it's going to matter in terms of you can't change therapy because you will continue the same treatment. So the question is not for changing the treatment, but very often we do ECRT, where the bone is put back and we don't get a proper assessment, a pathological assessment also of the necrosis. So I think that is one area where this can help you. The other thing is that if it was a borderline case for limb salvage, and I'm not certain whether the patient has responded well or not, and whether I should do a limb salvage or not, seeing a response to chemotherapy, particularly a good metabolic response, actually will tend to shift you towards doing a limb salvage, and vice versa. Not responding means you would probably think of doing an amputation rather than limb salvage. And we have also now looking into whether we can actually see where the response has come, because close to the vital structures like the neurovascular bundle, if you find there's a lot of viable tumor and elsewhere it has responded, maybe that is again going to change the way in which you're going to do the limb salvage surgery, whether you're going to resect the vessel or not. So we do a PET CT not really to look at whether we have bone mets, and I think it's absolutely correct that the amount of bone metastasis without lung metastasis is extremely rare, or to get multifocal osteosarcoma is going to be very, very rare without lung mets.
Right. So I think as a standard of care nowadays, we practice a PET CT or at least a bone scan plus NCCT thorax. But as Dr. Badra told, I don't think it's a routine practice to do a response assessment on a PET CT. But I think we have to understand the orthopedics thoughts on it as well.
In
So
fact, nowadays
for this
it is
patient,
sometimes difficult to get a bone scan. It's
yes,
very it's much easier to get a
it's
PET
easier to get a
CT.
PET CT than getting a bone scan. True, sir, true. So the diagnosis was confirmed as left femur osteogenic sarcoma, which was non-metastatic. So Dr. Sandeep, what would be the other baseline investigations which you would like to do before initiating chemotherapy?
So this is 14-year-old child who has localized osteosarcoma. We have to start chemotherapy. So first of all, I will sit with the family, explain them about the diagnosis, the staging workup, and how the treatment is going to be, and prognosis, expenses, everything in detail, and we'll take a written consent for chemotherapy. Because this patient will receive chemotherapy, so baseline investigation like complete blood count, liver function, kidney function, and LDH are mandatory. And then we know that this patient is going to receive cisplatin, so pure tone radiometry baseline, that is what we do. And for doxorubicin to monitor the cardiac function, we will do 2D echo. Generally, we don't do a GFR scan for everyone in our setting, but if it is available and one has to do, they can do that also. Now, say young child, 14-year-old, definitely the fertility preservation counseling must be done, and sperm cryopreservation should be offered to the family. But I would say not more than 10% of our young male patients are able to undergo that procedure, but definitely we should offer it. The one thing that we often forget is that before starting chemotherapy, we should include our rehabilitation team into our consultations, so that the exact weight bearing, how much weight child can bear, and the range of motion that is expected, and rehabilitation that has to begin right from the diagnosis. So rehabilitation team should be part of our team right from the diagnosis.
Yes, Dr. Sandeep. So the patient, after all the initial evaluation, of course, fertility preservation was not done, counseling was not done for this patient, but because we were planning for MAP chemotherapy, so there are different thoughts, like MAP chemotherapy generally tends to produce less of fertility problems, but if we are giving a chemotherapy protocol which has got more of alkylators, the chance of having infertility issues is higher. So this particular patient, after all the other baseline investigations, was started on MAB chemotherapy protocol, which is the protocol that we follow at our center on 2/11/2024. So Dr. Badra, this is more of an academic interest for the students in the group. So what is the role of neoadjuvant chemotherapy versus, we are quite sure that we always go ahead for neoadjuvant chemotherapy, but what is the role of neoadjuvant versus adjuvant? What are the principles of neoadjuvant? How many drugs? What is the evidence for these?
Yeah, thanks, Benita. So I think the role is mainly there of chemotherapy. So in the era where only surgery was done and your EFS was less than 20%, and with chemotherapy in a localized disease, with the addition of chemotherapy to surgery, it has increased to 50 to 60 percentage in localized disease. So chemotherapy is vital. Now, whether you want to do it neoadjuvant in a neoadjuvant setting or an adjuvant setting, I think it depends upon the setting, and mostly in India, because we see patients with advanced disease and all those things, and we need, as Dr. Manish pointed out, we have more of limb salvage surgery now, and your amputation rates have come down to less than 5%. So because they are children, you need to plan the surgery, you need processes planning, all those things. You do start NACT, and it does have collateral benefits, like your surgeries, you have a more organized tumor, less vascular field maybe later, and you can plan all the processes, and your surgical planning can be done. You either treat the micrometastatic disease, because this is a systemic disease, osteosarcoma and Ewing sarcoma both. So it also has collateral benefit, and it also adds that you can also prognosticate the patient based upon the response to NACT. It gives you an opportunity for the same also. Otherwise, the only randomized trial is from POG, which has seen whether an ACT versus ACT, whether there is any difference in outcome. There was no difference in outcomes as such. And your rates of surgery, limb salvage was also the same in that trial. Beyond that, we don't have any more evidence. But the most crucial is the application of chemotherapy in a curative setting. And we usually end up doing NACT, but your local therapy should not be delayed beyond 12 weeks or so. You should ideally do it after 4 cycles of chemotherapy.
So this debate.
Yeah, Dr. Manish, you want to add anything? I mean,
no. So I think the benefits of neoadjuvant chemotherapy, even for limb salvage surgery, are now extremely well known. I think it's very useful to have the reduction in vascularity have a completely lytic area, ossify a bit and improve that strength of that bone. If there is a pathological fracture, an undisplaced fracture or something, it allows the fracture to heal. And more importantly, the patient who has presented with a lot of pain benefits by getting a lot of pain reduction once the chemotherapy starts. So I think these are benefits which are actually not given that much importance. But as a surgeon, I think the neoadjuvant chemotherapy to me is very important.
Yeah.
Before we go ahead and plan what to do, particularly those people who have not responded, like we said, we may think that because we've given chemotherapy, disease has increased, and then we have not been able to do limb salvage. It actually helps you select those cases, because if they have not responded to chemotherapy, there is very little chance that they would be long-term survivors. So that at least helps you decide what kind of surgery you want to do in a country which with patients with so many limited resources. I think it is very important to know what kind of prognosis you are expecting in the child before putting a lot of money into limb saving surgery on that.
So, Dr. Sandeep, we do debate a lot about whether high-dose methotrexate, as per the Western literature, MAP protocol with high-dose methotrexate is the standard of care. But in low middle income countries like us, the administration of high-dose methotrexate is not that easy. So what is your take on the role of high-dose methotrexate? Is it really feasible in a LMIC like us?
To me, the biggest advantage is preservation of fertility. I think if you give ifos, we all know that 3 drugs are required. So if you don't give methotrexate, you're going to use ifosfamide.
Ifosfamide, yes.
And ifosfamide, I think the doses that are used in osteosarcoma, there is a more than 90% chance of having complete azoospermia. And that's completely irreversible on that. So I think given a choice in children, particularly in children, I would use the MAP protocol. I don't see any downside of it. It requires a little more monitoring. I don't think it is actually more expensive, because we've been using it even at Wadia Hospital. Almost all children get the MAP protocol. I think it just requires a little more monitoring rather than anything else on that. And we are able to operate after 2 cycles of MAP, means 10 weeks instead of 4 cycles, which otherwise are used with the non-MAP protocol.
No, I agree with most of the things that Dr. Manish.
What is the protocol that you follow in your center, and what's your experience?
So I agree with most of the points that Dr. Manish has said. And I think this is one of the most debatable issues that we have when we discuss about the chemotherapy in osteosarcoma. If we look at the published literature, there is hardly any randomized trial which have compared the high-dose methotrexate and non-high-dose methotrexate-based protocol in osteosarcoma. So the most robust evidence that we have is from the Euromos trial, where they have shown that in patients with resectable osteosarcoma, the event-free survival of around 75% in non-metastatic setting. And this is one of the best results that we have so far. So definitely in children, this is standard of care in Europe and North America. But at the same time, we have to see the logistics that we have. It requires lots of supportive care infrastructure, pharmacokinetics, recovery, hydration, management of toxicity. And in our setting, actually, we had an opportunity where we could compare the IAP regime with the MAP regime, because from 2011 to 2016, we were using the two regimes, and we have published the data. So around in 100 patients, around 60 patients received MAP chemotherapy and around 40 patients received IAP chemotherapy. The event-free survival difference between the two groups was 8% in favor of MAP, although it was not statistically significant as in most of the published literature also. But I think that 8% might be because of the fewer number, and it might be more if that number is greater. But at the same time, the only thing that we noticed that the supportive care requirement with the MAP regime was much, much higher compared to IAP regime. The duration of treatment and the toxicity and the cost of the treatment was significantly higher with the MAP regime compared to IAP. It is not easy to deliver a timely MAP regime in a consistent manner. 12 grams per meter square every week is not easy to give. And sometimes if somehow the morbidity is such that we are compromising the intensity of cisplatin and doxorubicin in delivering high-dose methotrexate, it might be counterproductive. So while choosing a protocol, I think we should focus on kind of supportive care infrastructure we have, what kind of patient profile we are having, and depending on that, we can choose a protocol. Definitely non-high-dose methotrexate-based protocols have a reasonably good outcome, but somewhat lesser compared to MAP. But again, there is no randomized trial to address their comparative efficacy.
Even in our experience, until around 2015, we were giving the IAP chemotherapy. So at that time, our survivals were quite less actually. So this was RCC data that was published, and our 3-year disease-free survival was only 44%, with around 55% for localized. So in 2016, we actually started giving the MAP chemotherapy. The tolerance to the MAP chemotherapy was quite good. We were able to deliver it, but the problems we faced were, one was say they expect the MAP chemotherapy to be completed within 29 weeks, but in our study we found that it takes on an average of 40 weeks. So might be due to the difficulties in getting inpatient beds, might be due to the toxicity profile, which we are finding it hard to manage. So only around 4 patients we had to change the chemotherapy protocol due to toxicity concerns, but the others tolerated well. Now, from 2016 until 2024, until now, we have been giving MAP. We are in the process of analyzing our data. So maybe in another 5 to 6 months, we'll be able to share our experience with giving high-dose methotrexate-based chemotherapy. But I would like to know from Badra, because they have one of the biggest.
I would like to add one more point. I would like to add one
sure.
more point. If we look at this Euromos protocol, the total duration of treatment is 29 months. And we look at our last 80 patients where we have given MAP. Since 2017, we are giving only MAP chemotherapy to all patients with osteosarcoma. Only 60% of the patient could complete their treatment in 30 weeks. 40% patient, as you rightly said, required at least 40 weeks of therapy. And this was because of the interruptions related to chemotherapy. So delivering timely chemotherapy in a MAP-based regime is really challenging in our setting. I think that has to be taken into account. Yes.
Yeah, I think Tata with the OGS-12 trial has got one of the biggest, they have given the biggest number of patients with a non-high-dose methotrexate-based chemotherapy. So what are the lessons that you learned from this OGS-12? What is the take-home message for the others from this OGS-12 trial, Badra?
I do echo the sentiments of both you, Binita and Sandeep. So for us, OGS 2002 actually stemmed out of the logistic issues only, because for us getting beds is it's not at all possible, because we have a huge volume of patients who require HDM takes inpatient admission for BLL, we have got a waiting list which might overflow for weeks. But so to have a 12 gram per meter squared inside, that means the clearance, everything, that's 4-5 days minimum of an inpatient bed, which is out of the question for us right for the moment. So I will put it at that way. So I can only just say that our experience with OGS, our outcomes, they're fairly okay. When we analyzed our pediatric only patients, what we found was we had a 3-year EFS of around 52% in localized disease, but it was around 50%, 48-50% 4-year EFS, and it was coming down. So we still have to see the long-term outcomes. So we don't have much of toxicity on OGS 2012, not much inpatient admissions. We have in between maybe 1% inpatient admission. Otherwise, our FNs and complicated FNs are very less. So, and we do have mucositis, but even that is not as much we would expect in what we see in BALL with a 5 gram per meter squared methotrexate. So we have given high dose in relapse certain situations. They do have delayed clearance, and they do have mucositis, and their inpatient admissions go on along. So that is with the minimal, the few handful amount of recurrent OGs where we have gained. So ours is mainly logistics. So I don't, as Sandeep and Binita said, we don't have comparison. So I think we just have to take it with what is there.
What we have.
Yes, and we cannot compare more on this. So,
Yeah.
But if you look at the Euromos data, they have included patients with an resectable osteosarcoma localized. Their outcome, event-free survival, is 76% compared to to 55% that we have. So definitely, if conditions permit and you have supportive care infrastructure that can support MAP regime, that should be the first.
Yeah. Wherever you can, wherever it's feasible and logistics don't is not a problem, you can go ahead with MAP. There is no problem at.
Right. So we started on the MAP chemotherapy, and after week 10 of MAP chemotherapy, we actually reassessed the patient. So the tumor size was remaining stable, but the contrast was slightly lesser. So what would be your advice for the local management for this patient, Dr. Manish, with such a huge tumor?
So I think we need to see more images to know how much it is extending proximally and distally. So proximally here, it looks like we will have to resect the hip, the head of the femur. But distally, probably we have enough length to be able to put in a prosthesis for the prox. So it could be a long proximal femur prosthesis for this child. Now, if you don't have enough segment down and you have to save the knee, you can radiate a portion of the femur and reimplant it and put
I had the MRIs with me, but for want of time, I'll not be able to show the videos. That's why. So the patient underwent wide excision with endoprosthetic replacement in the ECRT on the 10th of January, and adjuvant chemotherapy was, I think I'll just skip for want of time. Adjuvant chemotherapy was started. So this was the post-op slides. Dr. Sindhu, your opinion on the...
Yes. Yeah, in the first image, we can see the viable tumor cells with this dense sclerotic bone tissue. And the second picture shows some amount of fibrosis with some loose stroma along with the dense sclerotic bone. And the upper half of the picture shows the viable tumor. So the below one is the fibrotic, the responded area of the tumor, and the above one is the viable tumor section. So roughly it contributes around 30 to 40% of necrosis and fibrosis. So not only necrosis accounts for the tumor response, even fibrosis and the acellular osteoid also accounts for tumor response. So 30 to 40%, it's actually a poor response.
It's a poor response. So I think we have already discussed this part where the role of, is there any role of chemotherapy if, augmenting chemotherapy if there is a poor response. Multiple studies have actually told us that even if you augment therapy after a poor response, it's not going to improve the survival. Even if you increase the treatment in the neoadjuvant phase and try to increase the necrosis, that is really not going to really translate into a survival benefit. So he completed the plan.
Just one more thing I would like to add. So definitely the intensification of treatment for poor histological response has not worked, but this has to be seen in the context of your frontline therapy. If somehow you have used 2-drug therapy and you have poor histological response, we don't have a data whether intensification of therapy for this patient will be beneficial or not. This has been mostly seen in context with 3 or 4 drugs. So many centers in India are using 2 drugs, and it is a good opportunity for them to actually explore this option, whether intensification in those cases will be helpful or not.
Oh, that's a very important point. Thank you, Dr. Sandeep. Right. So he received this particular child. He received the adjuvant chemotherapy and completed on the 9th of June. What are the follow-up surveillance guidelines? I think all of us, we have a set of surveillance guidelines. So Dr. Badra, just quickly.
So, Pinida. So, I think surveillance would, it can be, you have rightly pointed out, we have our own surveillance. So, there are so many surveillance guidelines available. You have the International Guideline Harmonization Group recommendations. We can follow that. So, you need to look at both the toxicity, late effects part of the, as well as the disease surveillance. So, that's 2 parts for a surveillance. So, disease surveillance, usually local recurrence, as well as you know, the most common site of recurrence is in the lungs. So so you can imaging, so chest imaging and local imaging plus clinical examination for the disease part, and for the, depending upon the drugs that have you used, because most of these are anthracycline based one, you do 2D echoes as per the, you can do as per the IGH recommendations.
So the patient was kept on follow, but after treatment-free interval of 10 months, the routine follow-up chest X-ray showed a suspicious lung nodule in the left lung. That was in April 2026. So the patient was further evaluated with the PET-CT, and there was only a single metabolically active lesion. So he underwent a WATS wedge resection of the left lower lobe on the 15th of April. And this was the histopathology. The resection margin was negative. Dr. Sindhu.
Yeah, in the first image, we can see the normal lung tissue. This is a normal lung alveoli with tumor here. So the second image also shows a similar high power image of the tumor with showing a nice pink acellular osteoid lined by this plump osteoblasts, which are the tumor cells, with some bone formation here. So this is metastatic osteosarcoma.
Thank you. So, Dr. Badura or Dr. Sandeep, so when a patient relapses like this, if now this is just a metastatic relapse to the lung, which has been excised completely, so the wedge resection has been done. So what would be your further take on it? How do you prognosticate this patient? What treatment advice would you give for this patient? Treatment options, anything available further?
So role of chemotherapy in the relapse setting is very debatable. Some people use it for patient who relapses less than 1 year, and for late relapses, definitely role of chemotherapy is very, very limited. The primary treatment for relapse osteosarcoma is surgery and only surgery. And especially when the patient has received intensive chemotherapy like MAP, further chemotherapy is unlikely to add to the survival benefit. So most of the patients that we have that have relapse after MAP regime, we just offer surgery. We don't offer any chemotherapy, irrespective of timing of relapse. But definitely, the data is not very clear for early relapses whether chemotherapy may be beneficial or not. For late relapses, it is very clear that only surgery is enough. This is how do we proceed in our setting.
Are there any experience with giving tyrosine kinase inhibitors or other targeted therapy in recurrent osteosarcoma? We usually have never given actually.
So I will quote Sandeep, what Sandeep said, surgery is the most important factor in determining whether curative or not in a relapse setting. And the treatment at relapse is surgery, and again relapse is surgery, surgery, surgery. So if you have limited lesions which are resectable, you go ahead with surgery. When you have attained a CR2 or a surgical CR, the role of chemotherapy is very debatable, and there are no specific guidelines, no trials, no evidence we'll get because the numbers are less and it's very heterogeneously practiced, and it has not shown to improve EFS as such from what the limited information is. It maybe it might prolong the survival with disease if you're giving it in a pallet. Other than that, we do surgery wherever resectable. Only in selected cases we have given chemotherapy, yes, relapse setting, tyrosine kinase, even in the upfront relapse refractory or in these settings, it has shown responses, but it has not, there are no data with respect to survival. And these do have toxicities. So as of now, I don't see TKI in the relapse setting. It has to be in a control setting. We have to test this and see whether it is translated. So whatever data it is there are responses, but no survival benefits, even short-term survival benefits.
Right. So after wedge resection of the lung in this patient, I just get the patient at a close surveillance. After explaining to the parents well that we don't have any other options available and the chance of survival for this child is definitely less than 20%. So even though that's an unfortunate situation, that is the best that we could offer to the child and the parents. So I think we'll stop here. We've just tried to cover the case scenario of a child who was diagnosed with a non-metastatic localized osteosarcoma. I've tried to guide you through the management decisions. Unfortunately, the child relapsed. So whatever was best possible in our situation, we have offered to the child. And now we just have to keep the child under surveillance and wait to see what is happening. Thank you so much. Thank you, Dr. Manish. Thank you, Badra, Dr. Sandeep, and Dr. Sindhu for this panel. Thank you so much.
Thank you so much. So I think majority of the questions has been answered. And as we are working in the resource limited setting, one of the questions that was in the chat box that can we proceed to high dose methotrexate without monitoring methotrexate level? So I think it's not a medically legally justified. So if it is not possible, better to go with IAP protocols rather than using the high dose methotrexate in that scenario. So with this, we are coming to end for today's discussion. Thank you, Dr. Manish Agrawal, for his valuable presence and giving us the insight from the surgeon's point of view, which we less commonly think about. And we know now with indigenous implants and can kit support, the scenario is going to change for the way we manage the osteosarcomas. And Dr. Vinita ma'am for moderating this wonderful panel discussions. A single case, but lot of the practical things were covered, and all the panelists who answered so well and give us this valuable insight. So thank you, and see you all the next month with another webinar. Thank you.
Thank you all so much.
Thank
Thank
you.
you. Thank you. Thank you.